Hello listeners, welcome to Views on Health. A great pleasure to have with me on the program Dr. Sajith Ranatunge, Consultant Surgeon of the Accident and Orthopedic Department, National Hospital of Sri Lanka. Tonight the focus is going to be on surgical treatment for trauma. We did discuss how trauma takes place because of road traffic accidents, the number of deaths that Sri Lanka is experiencing at this point in time, the number of people who are dying because of road traffic accidents, and also highlighting the fact that many are sometimes laid up for life if they can't recover because of the nature of their injury that they had sustained. Having discussed that on the program the last time around, tonight it's going to be how these victims are treated when they are brought to the hospital. Over to you, doctor.
Yes, actually, in National Hospital, what we are the main referral center for the other hospital. So we get two types of patient where we get transfer in from other hospital and then direct admissions, where the injury happen around the Colombo city. We get patient directly to the National Hospital Trauma Center. We have a separate, we are special because we have a separate center for trauma, which is unusual for other centers. And then we receive all the trauma into one place. So that we have made it like all the staff are trained and set for treat. Initially what we do is we have a place called triage where you sort the patient, and then from the triage itself they decide which area to go. Like we have a resuscitation room where very serious critically injured patients are treated, and we have a trauma OPD, outpatient department, where patients who are minor injuries are treated. In between we have a place, we call it trolley side. It's in between very critical and the minor. We have a place actually in same floor. We have theatre, general surgical theatre, and one orthopedic theatre, and then all the treatment initial assessment department, and then we have a separate 2 wards for male and female in first floor. And apart from that, we have a separate unit for neurosurgery, that is brain and spine are looked after, and we have a separate wards and theatres for orthopedic surgeries also.
So obviously once they are brought in and you assess the nature of the injury, you take them to that particular area. Now from your side, you as a consultant surgeon, how do you go about this? Of course, it depends on case to case and the extent of injury.
Yes, of course. With the help of emergency physician, we manage very critical patient at the initial stage where to stabilize them for a surgery or other intervention, where under guidance of, we have 6 surgeons who work on rotation 24/7 365 days, and then under the guidance of general surgeons, and then we have a junior staff where they attend immediately, and then they will convey the condition, and then where necessary we will be directly go into the patient, and if necessary actually we have run into theatre with the patient sometimes. Very rarely we get we call cardiac arrest at resuscitation room, where all the specialties related to that comes and try to get the patient back.
So doctor, when you take their injuries per se, we are now focusing on treating the injured patients, and then obviously when the assistant, like you said, you have the team ready and you have the facilities, and we are very happy that Sri Lanka is that geared, the National Hospital in particular, to deal with such cases. Now, if a patient is really bad and it's immediate surgery from your side, is there anything like the terms of preparation, like informing family? Sometimes the family may not be around because this has happened on the road, and then the patient is brought in. You may not even know who the family is. It may not be possible at that point to even locate somebody. How do you proceed?
Of course, that is one of the major area, because but from the legal point of view, we, in case of emergency, we are to life save, we can take the decision on behalf of the patient, where sometimes patient come unconscious. So in that situation, if we don't have a family member, then we have to take the decision on behalf of patient. That is legally we can. So we are bound to take the decision as a surgeon, consult surgeon. So then we don't need, for a routine surgery, we don't need the signature of the patient. But in case if the patient is conscious enough to take the decision, and then we will let him sign before the surgery if necessary. There are instances where there are a lot of instances we have to take the decision, and then sometimes what happens is if you get information from family or people who brought them in, might be contradicting to our decision. So I think probably what we do is we directly inform them this is what is necessary for the benefit of the patient.
Doctor, when you take the patient, the victims rather, to recall that the last time around you said you see most of them in this productive age of 20 to 30 years, and they are motorcyclists, and then you get the pedestrians who are in the older age group, 60 plus, who have been victims of trauma. Now, in all those situations, you explain that you will take the decision as and how the situation presents itself. But when you treat them, and the extent of injury could be such that you might have to go in for long surgeries, as again you explained the last time around, which the number of hours you spend, you would be otherwise conducting more operations in that time of other patients. But then this is a situation that needs time, and you need to deal with them. Now, if you take a person with like a head injury, roughly how long does that take to attend to in the theatre?
Of course, actually it's we have a separate team of neurosurgeons who are very capable of performing, and then under them they have well-trained medical officers who will attend to the patient surgically also. Actually, most of surgery runs beyond 2 to 3 hours, which is if it is major one. So there may be surgery which might be short lasting, but I think even though we have a separate unit, number of staff we are spending, and then the number of hours we are spending on the particular neurosurgery, head and spine. So I think we are losing a lot of time for the routine surgery. Maybe even we might be losing a patient who are supposed to have surgery for cancers. So that is the effect you might get from a trauma.
Another point that we have stressed in the past is that this service is offered free of charge. Am I right there?
Yes.
It still stands that way.
Stands.
So that means there is a person who has caused the accident. Sometimes, of course, it could be the carelessness of a pedestrian, not the driver or the rider. But end of the day, most of the time, it's the other way about. Mm-hmm. So somebody has caused somebody a grave injury, and then you have to treat that person. The government does it. The Ministry of Health provides everything for free to take care of that patient at a tremendous cost to the country.
Yes.
While the person who caused the accident doesn't seem to pay anything.
Yes.
Am I right there?
Yeah, actually, that's real truth. Actually, if you see a patient who has had a head injury, sometimes they had a major surgery, and then ICU care sometimes goes up to 35 days, maybe 14 to 1 month almost. Like if a person spend ICU care, with the ventilation, all the machines set in, with the treatment, antibiotics, and then other medications, I'm sure it's millions, not just lakhs, actually some millions. So I think that is the amount we lose from one single case. So I think that is huge, but people don't understand that in single incidents can cause that much of harm.
Because to the best of my knowledge, cost runs into billions and billions of rupees.
Should be
annually.
Annually. Yes, definitely, yes.
Because this is some sort of no recent statistics and figures, but certainly for a few years back, into billions, the cost to the state to treat such patients, which I think the people at large take for granted because they're not paying for it.
I think we could have escaped from IMF loan if we save life for about 3-4 years, actually.
That's a good point, doctor. That's a very good point. There may be something that the Ministry of Health can highlight, that the country need not spend this money unnecessarily and rather put it into more productive use for the country.
Definitely,
good point, doctor.
Yes.
Thank you so much for saying that, because we are in the midst of this crisis in the country, economic crisis, and we are coming out of it, and the government is addressing the issues. And to think that this money that is just actually going down the drain, I would think, because of some people's carelessness on the road.
Yes.
I didn't think of that, and I'm so happy you brought that up, because it really stands to reason. And I wish the Ministry of Health will highlight that to the general public. The amount of money that is being spent on treating trauma victims could well be channeled to address the country's economic issues. Thank you, doctor. Yeah. Going on from there, so it's also rehabilitation thereafter, which is also can be, as you said, long-term, short-term. Could you highlight?
Yeah, actually, I think we just see the initial part only, like deaths and then amount of cost from the but I think for the family, it's loss of breadwinner sometimes. The ability of the breadwinner, so the financially, and then they have to be on rehabilitation for a long time, where it might, the government and the family might have to get the burden for years and years. So that is, I think, and then we have a clinic, the separate clinic for orthopedic department, where they handle most of the fractures. So they will look after, but I think they will look after only the treatment side. So I think we have a separate rehabilitation center for in Ragama. I think all the facility we can't provide, for the 100%, because we are not as financially, and as a resource, human resource also not enough to cater that much of a trauma. So I think prevention is the best.
So what would you advise for prevention?
I think, as I said initially also, this is what we have to think twice before you act. What I would say is, we call like paninna peresita balnu. Then I think we have to change it naginna peresita balnu into the vehicle. So I think we have to change the attitude of public, where at least before you ride, think that you will save one life. That should come from everybody, I think.
So that's the message you want to give.
Yes.
Doctor, now treating the trauma, back to that aspect of the discussion. You spoke of having a well-equipped area, places, and you have the staff trained, all of that. And you said the facility is available 24/7. Now, if you take a victim of an accident in a really bad injury, at that point in time, irrespective of the time of day, is the medical team ready to deal with it? So something happens in the night.
Yes, I mean, number of staff might be not as much as of daytime, but we are in a position like we have on-call team where we can get down at any time. So I think because we have like first on-call, second on-call system where you can get down the second person in case necessary. So at the moment we are in a position that we can handle most of the cases.
So that is all in place.
Yes.
So that is tremendous. So the surgeons and all are there. If on call, if need be, they can be contacted.
Yes.
And they will come. If A can't come, B will be there.
Yes.
And the process is in place.
In place. Yes.
That's good to know, because sometimes people wonder. Again, from a lay perspective, it happened at this time. Do we have doctors? I mean, so
we are always there.
But the accident and orthopedic department is geared for that.
Geared for that, yes.
Thank you, doctor. So it's time is catching up with us once again on the program. You spoke of some statistics the last time around, and could you just recap for the information of our listeners?
Yes, actually, we in view of like minimizing or making it less. 50% of injury to prevent deaths. 50% deaths. Like every day it happens. 6 to 8 deaths per day, and the serious injuries are much more than that. So roughly, if we see a week number of victims of a week, around 1,500 visits into the unit, and then to about 260 road traffic accidents. Out of that, more than 50% are motorcyclists. And the others are pedestrian. From the motorcycle itself, more are pedestrian who injured. So I think these are major things. We have to look at when it comes to prevention.
Thank you, doctor. And so there we end this interesting discussion on surgical treatment of road traffic accidents. And going on from there, we sincerely hope that the program that you envisage to educate the public, to train members of the public to deal with trauma on the spot, so as to facilitate I would say the patient not going through further trauma till such time medical arrives, will all bear fruition in the near future.
Yes, that's our hope, actually.
Thank you, doctor. And so we end this interesting discussion on surgical treatment for trauma. And thank you to you, Dr. Sajith Ranatunge, consultant surgeon of the Accident and Orthopedic Department of the National Hospital of Sri Lanka, for once again being with us on the program. Thank you, doctor.
Thank you very much.
Thank you too to Damayanti Kolumbage for technical assistance. I'm Fatima Razikada saying good night, and looking forward to your company next Monday, same time on Views on Health.